So greetings, everyone. Thank you for taking the time to join us today for a follow-up discussion around reimagining healing after harm, the potential for restorative practices, and we will focus on New Zealand's journey today. So my name is Alison Koyman. I'm one of the co-chairs of Patients for Patient Safety Canada. We are a volunteer-led program of the Canadian Patient Safety Institute and the Canadian arm of the World Health Organization's Patients for Patient Safety Global Network. So joining me as moderator today is Sandy Cossey, Senior Director at the Canadian Patient Safety Institute.
Hello and welcome, everybody. I'm joining you today from Edmonton, Canada, which I respectfully acknowledge is a Treaty 6 territory, traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. We respect the First Nation treaties made on these territories, acknowledge the harms and mistakes of the past, and dedicate ourselves to collaborate in partnership with First Nations, Métis, and Inuit people in the spirit of reconciliation. I ask you to please join me in taking a moment to acknowledge the people and territory in your region. Very apt and appropriate opening for our discussion today. So back to you, Ali.
Thanks, Sandy. So to frame this conversation today, I'll just give you a brief bit about my journey here. In 2012, I received an erroneous diagnosis and subsequently underwent an unnecessary bilateral neck dissection. The surgery caused me a significant amount of harm, left me disabled and in chronic pain, and also was the ending of a career that I loved as a licensed practical nurse. I felt really betrayed by a healthcare system, which I had placed implicit trust. And what I really needed was some help and some kindness and some humanity. And my expectation was that would be there, and it wasn't. So I thought perhaps that my experience was an isolated one, but what I found was that almost everyone I met could recount a story like mine. And we as harmed patients are incredibly disadvantaged in this space. So there's been a significant focus on reducing preventable harm in the healthcare system. But what we've observed is that reconciliation and reparation post-harm appear to elude us in this context. Our collective observations demonstrate the need to do something differently. In our August webinar, we explored programs and best practices to responding to harm in 3 countries. And there was a lot of interest in New Zealand's model and their approach. So this is the focus of our conversation today. And in this webinar, we will further explore New Zealand's approach to healing after healthcare harm from surgical mesh. So we are curious to learn about what was the impetus for the use of a restorative approach, what inspired the choice of a relationship-centric and reconciliatory model, how did restorative practices support the co-design process between consumer or patient advocates and the Ministry of Health representatives? And how do restorative approaches support New Zealand's commitment to Te Tiriti o Waitangi, which is the treaty that determines the partnership between the Crown and the Indigenous people in New Zealand? So this session will be formatted into 2 sections. First, we will hear from our New Zealand friends who will walk us through the aforementioned questions and fill in some of the contextual pieces for us, and some humor likely, I think, we'll get from these guys as well. We then will ask our panel of experts to join in for a discussion. We've got an all-star cast here, really excited. And our hope today is to learn from the New Zealand experience and to begin to explore what this potentially could look like in the Canadian context. So we'll be looking for your insight. I do need to clarify that this webinar is an opportunity to explore the use of restorative practices in the healthcare context. It is not our intention, and neither are we in a position to provide clinical or legal advice. And back over to you, Sandy.
Thanks so much, Alison. So before we get started with the presentations, I just wanted to briefly orient you to our virtual space. Note that all of your lines are muted, but we encourage you to use our chat box features for discussion to engage with your panelists and with each other. And to familiarize yourself with the chat, you can please send a message to everyone stating where you are from, and you'll see that some folks have already started to introduce themselves to all of us. If you do have any technical difficulties, please direct your queries or inquiries to Janet Bradshaw, who is providing amazing technical support for us today. I do also want to let you know that this session today is being recorded, as we always do with our learning and development activities, and it will be made publicly available on the Canadian Patient Safety Institute website after the webinar. I do want to let you know, though, that we are very much intending for this to be a safe space for our discussion. I ask that the slides and the chat box discussion will not be shared, so we ask you not to share on the slides and the materials or any of the recording things that might be preserved in the context of our discussion today. Again, that's for both copyright permissions, but also because we want the chat box to be a really safe place for you to ask questions of the panelists and to encourage discussion, sharing, and learning with each other. I also want to acknowledge that some of the content of this webinar you might find emotional or perhaps even upsetting, given your personal circumstances or your experiences. I really encourage you to all practice self-care. Take a breath, step away if you need to, of course. We will include in the chat a few general resources that might be helpful to you, but again, we don't have the mandate or the ability to support individual cases or to provide any clinical, medical, or legal advice. But of course, this is a place for learning and sharing together, so if you'd like, please do share any resources in the chat box that you might find helpful or you think might be helpful for others. So our hope is that this webinar will help us reimagine healing after harm in Canada, but also around the world by learning from our colleagues, by learning that from those who have gone before us, who are setting the bar around some of those leading and wise practices from our colleagues in New Zealand. For learning and improvement and learning and sharing, we know can lead to greater culture of sharing and openness and transparency and safety improvement. So I have the great privilege of introducing our colleagues from New Zealand. I won't speak at length. Their bios are all available on the website where you registered for this event. We want to hear from them and not me. So let's dive in first from hearing from creator of Mesh Down Under, Carmel Berry, and then from Dr. Andrew Simpson, who is our Chief Medical Officer at the Ministry of Health in New Zealand, and Joe Whaling, Diana Unwin, Chair in Restorative Justice, whom you all met at our last webinar, and we just had to bring back Joe to hear from her one more time. So thanks, and over to our panelists.
I guess that's my cue. Hi, I'm Carmel Berry. I'm here in Auckland, New Zealand. It's the middle of the night for me. No, it's not really, but it's really early in the morning. I'm here probably most likely because a lot of what is going on here today began with my story, and that began in 2002 when I was told that I needed to have a hysterectomy, and I didn't want to do that. But in 2004, I was told, hey, it's a good idea now, we'll put surgical mesh inside you, and that will mean that not only will you have a perfectly healthy uterus taken out, but nothing will ever fall out again. So that was the rationale for me going ahead with the surgery, which I did. And I woke up screaming, and they said, something's really wrong. And they said, no, you're fine. Have some pethidine. You'll be fine, you'll be fine. And I wasn't, and I kept complaining. I was so much pain, and what's gone wrong. And I was in and out of surgery for a wee while, and eventually they sent me to a psychologist because they figured that I must have some kind of brain injury. And then backwards and forwards over the next few years, unfortunately, because of the timing of my case, our New Zealand's insurance system, I wasn't covered as a treatment injury because my injury was in 2004, not 2005. So hopefully a few more people have been accepted for a treatment injury than I would have been. But anyway, one of the people that gave an opinion about my story was a neurologist, and I made an appointment to go and see him, and he kind of said to me, you know, you've just got to stop being a professional patient now, because I'd spent 3 years, or nearly 4 years, seeking help, trying to fix myself, get an answer, and he suggested it was a good idea that I just went to bed. And so I did. And shortly we'll show you some slides, but and one of them is a beautiful drawing that my son made of how he saw me at the time. But while I was waiting in bed for many years, which was a long time, I happened one day to come across a YouTube video of a person in Bakersfield, California. Her name's Christine Scott. And it was a lady that said, I've won a court case against a mesh manufacturer, and they agree that the mesh has caused me this dreadful harm. And I thought, I'm not the only one in the world, after all. And because I had been told that by many, many people, that there was never anyone else that had that same problem that I did. And so I thought I'll make contact with her, and I did through Facebook, and she replied very quickly, and she said, Carmel, it's not just you and me in the world, there's thousands of us. The problem is that in the US, you're not allowed to talk about it because most of us are awaiting litigation. And so I'm the first one to have my court case heard. And so I thought to myself, well, if there's one other person in the world, maybe there's other people in New Zealand. And I had a conversation with the beautiful Chloe Johnson, who was working with the Herald on Sunday, which is one of our major weekend newspapers. And she said, this is a story. We're going to make something of this. And she did. There were several weekends in a row where we had a whole page or 2 pages, and eventually the full editorial column, all about the fact that this was going on in the world. And within minutes, certainly less than a day, I had made contact with the 2 beautiful ladies who are now my close colleagues, Patricia Sullivan and Charlotte Corte, who also said that they were experiencing the same complications that I was, and we should do something. And so I got my head around it, and I thought, okay, I'm going to make something. And so I created Mesh Down Under, initially as a Facebook page, just to see who's out there and join up and talk to each other and share our experiences. And within weeks, we had 30, 40 people. And after about a year, maybe we were up to 300. And there was a lot of conversation that someone should do something. And I suppose that I felt that on my shoulders, being that I'd created Mesh Down Under, that I should do something. So I started writing a lot of letters to initially politicians and doctors and healthcare people, our MedSafe, which is a part of our Ministry of Health, but is sort of separate, but like an FDA, so regulator of medical devices. And then I found out that, unfortunately, New Zealand has no legislation at all that requires any pre-market approval or even to any extent a post-market approval, other than if people make complaints about a medical device. And I started to collect quite a lot of information from what we call an Official Information Act that I put together, and I was talking to my colleagues and said, we've got to do something about this. And I then learned that it was an opportunity in New Zealand to make a submission to the government for requesting that the Select Committee would investigate something, and that was called a petition. So it took another year for that to get written. Charlotte and I did that together. Patricia, unfortunately, wasn't very well during that time, but she was incredibly supportive in the background, and certainly when we got to Wellington, our capital city, to present that petition, Patricia was there with us. So you'll see in the slides, we finally got heard, and the select committee then were, this was 6 years ago now, were coming into an election. So we got a wee bit of a pause, and then eventually the select committee came out with a series of recommendations, which were good, perhaps not as robust as we would have liked or asked for, but that then was given to MedSafe, again the regulatory organisation, to implement. And the people at MedSafe created a spreadsheet saying these were the recommendations and this is what we've done. And we decided it was a good idea just to let that play out over a wee while. But after about 4 months, there were tick boxes ticked, including things like, oh, we had a meeting with these people and we talked about this issue, and the outcome is that that's now ticked and sorted. And so after a while, I was like, oh no, something's not going on. So we would ask, again using official information, can we please see a copy of the minutes from that meeting, or who was at that meeting, or what the outcomes for that meeting were? And then we started to hear, actually that meeting didn't happen, or nobody remembers that meeting, or it certainly wasn't minuted. And at that point, we realised that we needed to take it a step further. And so we tried writing to the Minister of Health at the time and various other people, and the answer was always, it's all under control, just let us do our job. But clearly it wasn't, because nothing was changing. People were still coming forward with more and more and more mesh injuries. We were looking at ACC numbers, and it was going from 100 to 200 to 300, and it was getting close to 1,000 people with treatment injuries, and it didn't appear anything was being done. And I happened to notice, and so 3 years later, it was yet another election in New Zealand, that our Minister of Health happened to be local to where I lived. And so I thought, I'm just going to go and try and tell him himself that there's a problem. And I made a pillow, which you'll see in a slide shortly, because I couldn't sit very long or very well. And I thought that was a good graphic way of explaining the pain and difficulty that people were having after having surgical mesh in their pelvic regions, particularly women, but not only women, and a lot of men as well. And so we went along, I think there were 6 of us went to that meeting. I'm going to use the word rocked up. I think you'll like that, Joe, because that's been an ultimate theme that came through at the end stage of this process. But we rocked up and actually showed our faces and spoke with the Minister of Health at the time and assured him that it was a really big deal. And he initially said, just write me a letter, but we pushed it to the point that we actually got a short meeting with him. And the outcome of that was a good thing, and that was that he collected a lot of people together from the Ministry of Health and other interested parties, which included the colleges and the providers and MedSafe and and various surgeons, and we made a thing which was now become affectionately known as the round table. And that happened around a big round table, and there was suddenly, we felt like, hey, we're getting some progress here. And then about a year later, I had a telephone call, and that was Dr. Stuart Jessamine calling me to say, you know what, we've looked at everything, and actually we're putting a halt to the use of surgical mesh for transvaginal use in the treatment of pelvic organ prolapse in New Zealand, and all of those products will be withdrawn from the market. And in interim, we're also holding up any products that are available for stress urinary incontinence until we are reassured that the information for use has got updated information that doctors can see and hopefully pass on to patients in terms of the risks. So the risk-benefit profile was addressed a little bit better, not completely. And about 6 months after that, we had another meeting, and there was a conversation about back to the select committee recommendations. And one of those was very clear that the ministry and the colleges and everybody else should talk to the people that had been, unfortunately, in this position and hear their stories and let them tell their stories and let them be listened to. And it was that point in time that Dr. Simpson and his colleagues came on board in the program, and they did. They listened and they said, let's see how the people of New Zealand would like to tell these stories, and you can carry on from there. But what happened in the end was everybody that could and felt okay with it had the opportunity to tell their stories through a restorative justice process, which Joe will explain better than I could. And that all happened last year and culminated in a very emotional meeting with a lot of people. And out of that came a long list of actions which are in the process of being put together. And it feels amazing after all these years that one Carmel Berry and two beautiful ladies actually got to this point in time where reasonably almost always when anyone in New Zealand has a complication with surgical mesh, hopefully now that their surgeons and doctors and support people will actually believe them. So that's my story. Here's my pictures. This is the drawing my son made for his art project. That's a picture of me, believe it or not. I'm not quite that skinny. But it was him explaining to his colleagues and friends at school that that's what mum looks like in pain at home. So, yeah, it was really important. The next slide is the logo that was created for our group, which was, as I said, initially a Facebook page, then became a website, and now has become a recognised advocacy group. There's my best friends. So on the right of me is, in the red, is Charlotte, and it's me in the middle, and Patricia on the left side of me. And that's what we affectionately call ourselves as the Three Musketeers. And that's been adopted by various organisations and media, actually, is who we are as a group. You can see there, this is us at Select Committee in Wellington. Charlotte's there in the left, and that's me on the cushion, my beautiful soft cushion, and my handbag on the chair beside me, which was sadly left behind, but someone provided it back to me. But that is a select committee, so that's a representative of New Zealand government officials hearing our story. This is pretty much about a week or two later. We had a lot of media coverage about our story, and this particular shot is of two general surgeons in New Zealand who took exception to the news that mesh was a problem and wanted to reassure the people of New Zealand that hernia mesh actually was perfectly safe. And we know now, of course, that people didn't agree with that. This is it was a really cold day. As you can see, I had my sheepskin on. But this is the pillow that I took to the meeting with the Minister of Health 3 years ago. And good luck, good fortune, I happened to have, there happened to be a newspaper journalist there who took the photo and was front page news that day, which was great feedback. And, good opportunity to present the story in a different situation. Can we go back one slide just for a moment? Okay, so Patricia is there in the blue coat at the middle and towards the back. Spent a long time working with Massey University doing some research that was actually published about New Zealanders and the impact of mesh on New Zealanders. And we were given the opportunity Patricia was given the opportunity to present at a GP conference the findings of that research, and our lovely supporters and many mission-injured people came to the conference that day and held placards up and drew attention to the issue. And this is the first time that a lot of us had actually met in person, so that was a pretty powerful day. And the next slide is actually the day that we were all meeting in Wellington. And you'll see there we need specialist mesh clinics, we need help. And this was a group that were standing outside the ACC office in Henderson in Auckland. And we showed this picture to Andy and Joe and the team on the day. And I think everyone felt really connected. And we, Patricia and Charlotte and I, felt really supported by our people, by them making the effort to put this together for that particular day. And the final slide is, you can see there, One News, which is our one of our major TV programs. And this is where we get headline news about what we were doing and the restorative justice system, the restorative justice program. And yeah, it's a very proud moment to be right on the 6 o'clock news. And that's my last slide.
All right. Thanks, Kamal. The story always puts things in context again to sort of hear the history over time. I'm Andy Simpson. I'm the Chief Medical Officer at the Ministry of Health in New Zealand. I'm a medical oncologist by background. I've had the privilege of working with Carmel and her team and Joe probably since mid-2018, I think I came on board with this project. The first thing I want to do is just probably give you a bit of context around Aotearoa, New Zealand. So can I just have the next slide, thanks? Just a bit of background. New Zealand, we've got a population of 5 million. Our Māori population make up 16% of our population, and Pacific peoples another 8% of the population. Similar to many country populations, we have an issue with health inequities that particularly impact our indigenous populations. And for us, that includes Māori, and they quite often have a higher, worse outcome rate in many different parameters. And so that's one of the issues we're facing today, is actually how do we start addressing that? Our health system, we are publicly funded predominantly. 85% of health funding is through the public purse. Our delivery of health care is generally through our district health boards. We have 20 district health boards, which you can sort of see a bit of a structure there. So all health care is basically delivered through the district health boards. So people have free access to that. There is no co-charge or co-payment with healthcare through the public system. You can attend the hospital, the emergency departments, your operations, your interventions generally don't cost anything. We do have a other side of that to access primary care, to see a GP, quite often does have a co-payment associated with it, and that can create access issues. On this diagram, you also see the HDC there, which is the Health and Disability Commission. That is an independent Crown entity, so it doesn't. It is independent from the Ministry of Health. It is a monitoring body. It has got a Health and Disability Commissioner who is in essence keeping an eye on the system and responds to complaints that go to them. The Health and Disability Commission has also drafted the Code of Rights for the health consumer, which covers all the rights from right to information, right to make decisions, informed consent, and the health system gets held to account against that Code of Rights. Next to that, we have the Health Quality and Safety Commission, which is again is a Crown entity separate to the Ministry of Health, and its function is around quality improvement and clinical governance, and actually how do we improve clinical outcomes for people going through our health system. On the right of that graph, you can see a dotted box. That's entities that are independent to health, they have a health impact. One of those at the bottom is ACC, that's our Accident Compensation Corporation, and Kamal's referred to that a couple of times. That is a publicly funded entity, and it actually is about no-fault personal cover. So if you're in a car accident or something untoward happens at work, and also includes treatment injuries within hospital, the ACC will assess that and will pay you compensation and pay for corrective actions. That covers a lot. It does a lot of good things, but sometimes, as you've heard from Kamal, it doesn't necessarily cover the individual person, though it does cover treatment injuries. That gives you a bit of a background. Of note, even though 85% of healthcare is publicly funded, things like surgical mesh don't necessarily all happen in the public sector. And one thing that happened with surgical mesh that we've become apparent is even though we have a small private sector, over half of the surgical mesh surgeries that happen in New Zealand actually happen in the private sector. Can I go on to the next slide? Thanks. When I got involved in the story, as Kamal said, it was there had been a lot of activity in Kamal and Mesh Down Under had been fighting, would probably be the word I would use, for quite some time to get their story heard. They had been through the Health Select Committee, the recommendations had been made, but obviously that was not providing resolution, it was not providing any satisfaction, and there was a perception that the recommendations that had been made weren't being addressed. As Kamal raised, one of the recommendations from the Health Select Committee was actually acknowledging and listening to the stories. And so when I came on board, I joined the round table, which Kamal and her colleagues were part of. And we actually had a discussion, well, what would this look like? How would you listen to the stories? What is it that people want to tell us, and who wants to have the opportunity to do that? So we actually drafted a survey from the round table, and we've actually put that out, made that accessible to the public. It wasn't for a very prolonged period of time, but we got through November through to January. So I think we had about a 10-week time for people to submit their thoughts on this to the questionnaire. We had over 400 responses, and the questions were about, do you want to tell your story? If so, how would you like to tell your story? We didn't want to make the assumption that, A, people wanted to tell the story. We didn't want to make the assumption on how they might like to do that. The feedback we got was a lot of people were interested. Most people would like to have done it face-to-face, but for many, they didn't want to do it face-to-face. They would like to either do it written or some other formats. There was other commentary in there. So we stood back and sort of thought, well, what do we do with this? We were very cautious in a way that being a ministry-generated survey, that people would be watching how we looked at this and how we interpreted it. So we actually felt it'd be prudent to get an independent analysis of that survey. And we also felt it'd be very useful from that perspective to forego any biases that we may have that we've not recognised. If we had someone independent to actually look at the survey as well and make recommendations. To that end, I'd serendipitously run into Joe Whaling, and we heard all around the restorative practice stuff. So it actually felt like that would be a very appropriate place to seek that feedback. And Joe and her group did that. And then it was actually, how do we put this into place? So the ministry, subsequently to that, then commissioned the Restorative Practice Unit to actually lead us and commission through this restorative practice process. I might then hand this over to Joe, if you're happy to take it from this point, Joe.
Sure, okay, so thank you, Andy and Carmel, for that set up to sort of where we got to in terms of restorative practices. I'm going to just give you a very brief summary of restorative approaches and the principles that underpin them, because then I would really like to sort of walk through some of the steps that are here again from Andy and Carmel. Can I drive this? Can we just go back one, Janet? So I think we've missed a slide here. Go forward. Okay, that's fine. So restorative approaches basically represent a relational approach. So they recognise that it's relationships that make us human and harm us, and they can also heal us. So we start thinking about harm in terms of the relationships affected, and you've heard from both Andy and Carmel there about the relationship that consumer advocates have with the government, and these words like fighting and difficulty and some conflict that characterise those relationships, but it also can be the therapeutic relationships that Carmel described between a doctor not listening to her concerns, raising her concerns. And the approaches we use, they can be proactive as well as reactive, because we understand that when there's positive relationships in place, then it's much easier for us to respond to harm because of that. And our project used all of these approaches, both proactive and reactive. So, for example, in the co-design process, we had to start with that reparation of the relationship between consumer advocates and the Ministry of Health team. And then we used proactive approaches throughout our co-design process. And those helped us to establish group norms, decide on the values at the outset, and also just kind of helped us when we came to bumps in the road throughout the process, but to be able to have like really honest, open conversations about difficult things when we have very different perspectives sometimes around the table. And the overall aim of the project was to respond, understanding the harms and needs of the people affected by harm from surgical mesh, and the consumers and the health professionals that were affected, and the aim was to restore the well-being and the relationships. And a restorative response is characterised by these relational principles and values, and that includes things like participation, respectful listening, truthfulness, responsibility, taking, empowerment, and equal concern. And the goals that we have are clarifying what happened in the past, the human impact, the needs created, and then there's collaborative decision-making about how we might best promote repair and achieve positive changes in the future for everyone that's affected by it. And our practices that we use, like the circles that I've mentioned, they create the conditions for this empathetic dialogue and compassionate hearing. And people are asked to speak and both listen from the heart. And it's produced by bringing people into a safe space, into this face-to-face dialogue that tries to answer 4 questions. Janet, have the next slide, please. Okay, so what happened? That's the past focus, and this is what we tend to focus far too much on when we look at safety issues. So what happened in the past? But then, like, what is the experience, the human experience? What impact does it have on people? And the stories that people tell, they're believed and they're understood to be the truth from that person's perspective. So that's different to seeking proof. This is about validating experience and understanding what is needed for all the individual parties that are affected by it, and how we might restore well-being and make relationships right and trusting again. And then we also look at prevention. So how do we prevent it from reoccurring? And we have a lot of nuanced understanding there because of the fact that we use storytelling rather than a sort of preconceived questions. It's a very broad umbrella for storytelling. And Andy represented what we call a responsible party. Now, there were so many people affected by harm from surgical mesh, and because it was such a large-scale intervention, and because healthcare harm is usually unintended, unexpected, and unplanned, we had to think, okay, what is a responsible party? What does that look like? And this is the definition that I'm using for that. So if you just go to the next slide, please. So individuals, sorry, Janet, back one. Groups or entities that are identified by the affected parties as having a role to play in the occurrence of the harm or in the reparative or the preventative actions required as a result of the harm. And they're asked to sit and hear those stories and understand the impacts. Next slide, please, Janet. Okay, this is our team. You can see a lot of the people here and that Carmel has photos of, and just there on the right there is Professor Chris Marshall, who is the Diana Unwin Chair in Restorative Justice. And Andy and Carmel, I'm just wondering, we've talked a lot now about the context that kind of led up to the project and the relationship between the government and you guys. And I've talked about us using restorative approaches and actually the associated practices in our co-design process. And I'm just wondering how you would describe your relationship now and what changes you think or what contribution you think restorative approaches or the practices we use in the co-design phase have made to that.
Oh, so Carmel, do you want to go first?
That's a big question. I think the initial relationship between Nishtananda and the Ministry of Health was combative and adversarial and kind of blaming and, you didn't fix it when we told you there was a problem. And after the period of time when the restorative justice process was suggested, it was the word co-design came on board. And I think that was really important because we were all in it together, and that was required us to accept that everybody believed us and everybody wanted it to be a good outcome, and everybody wanted to work together. And the relationship was negotiated, if you like, but certainly became one of trust and respect and expectation that everybody would be honest. And once we got that kind of groundwork established, it became much less confrontational and much more working together to achieve an outcome that was good for everybody.
Yeah, I was going to say at the beginning, I think if I was being euphemistic, it was low trust. I think it was almost no trust at the beginning. And I can see why it was that. And so I think it was very much when we started getting around the table and actually sort of hearing the different lenses from each of our sides and what was important to each of us, and what were our parameters, and what could we do and what couldn't we do, and all sorts of things. So I think we went from low trust and I'd agree combative. It was almost, and I can see why it was on both sides. It was almost like, you're not responding, or you're not understanding our contexts. And so I think we worked through that. But we still had our moments. It was very easy as we worked through the process and we went through the listening circles in the 6 months. It was very easy that when things got stressed for whatever reason, sometimes there were stress points that happened, and one time I was misquoted in the media, and that created a real stress point. It was at those stress points, it was very easy to revert back to that initial relationship. Never really got back that far, but actually there was that risk that either side went back to that earlier relationship. But on that, everyone worked through that, and I think it was a case of, we held true. We had some rules of how we were going to engage with each other. We may have slipped at times, but we actually both sides held true to those rules. And so I think we've actually got a really good relationship now. And I think we've got a high trust. We don't necessarily think we'll necessarily do what each other wants, but I think we've got a high trust that we understand where each other's coming from and what's playing out.
Thanks, Andy. And I think what I would add to that is, the practices we use, the principles that underpin them are about democratic decision making and equal concern, and they create those just conditions for a high degree of psychological safety. And as you've just described, we recognise that we're not always going to agree on everything, but having that high level of trust moving into that space makes it much easier to be honest and open. And that's important to improve safety. So the first phase we had was listening circles, we had private meetings, and we had a story database. So we had multiple ways for people to tell their story. And the important thing about this is that people chose all those different ways, and they might actually choose more than one. So some people submitted to a story database a written submission, but they also came to a listening circle because they wanted to sit and tell their stories to someone they perceived to be responsible for the harm or for the reparative and preventative actions. And, the other thing is beautiful to see Carmel share that artwork earlier. We had all kinds of things in the story database, everything from photos, people brought pieces of mesh to listening circles, we had artwork, we had poetry, and it just really shows that allowing people to express their harm in a way that they're choosing is really important. And that's vastly different to the traditional inquiry approach that one would take. And in a circle, these were led by skilled facilitators from our team. It's a very structured and intentional discussion, and we used a talking piece to confer uninterrupted speaking rights. Can you just go to the next slide, please, Janet? So in these circles, these are some of the words that people described their experiences: grief, devastation, being stifled, feeling invisible, trauma, anger, mistrust. You can see there's a lot of trauma being expressed there. Next slide, please, Janet. And the predominant moods of the circle, this actually describes some of the words that we felt described the experiences of the 10 people that would come with us, support people to tell their stories. And Andy, I'm just going to ask you, we're quite short for time here. We've only got 5 minutes left to talk, but I'm just wondering, Andy, are you able to just give us some thoughts on what it was like to sit as a responsible party in one of those circles and hear this about the people's experiences?
There's so many words you could use, and many of those are on that slide. Actually, it was tough. It was hard work, and but at the same time, it was a privilege. Because you actually, I think one of the hardest things to do is just sit there and listen to start with, because we all know that clinicians, generally, if you're interacting with a patient, taking a history, people would say that you interrupt within 30 seconds. Well, we couldn't do that here. This is, it was the person had the floor and you just sat and listened. And so people might talk for half an hour, they might talk for less, they might talk for more. So you just sat and heard what they wanted to say in the way that they wanted to say it. And that was hard, but at the same time, it was incredibly rich because you heard what was important to that person. You heard it in a way that you would never have thought yourself. You got taken to places and taken into ways of thinking that you wouldn't go yourself. But obviously, this is what it was important for this person. You really heard the impact on their lives and what was important to them and their family and how that had played out, how long that had played out for. You heard some good stuff. You heard some bad stuff. I sat there at times thinking, really? Is that really the way the system's played out for this person? Or did that clinician really do that? And it was quite heartbreaking at times to sort of feel that that's what people have experienced from the system, because that's not the intent of the system. It's not the intent of the clinicians. Everyone's there to do good, but this is what this person had experienced. So how did that happen? How could we do things to improve the system, to mitigate that happening? We just do not want that to be happening. It was also really impressive to sit in these circles because you had 10 people telling their story. And to me, it appeared that they were getting a lot of value from that peer support. They were being heard by their peers. They could share stories with their peers. They could validate themselves with their peers, which I think is something that we couldn't do as clinicians because we, by the nature of that, we sometimes on the other side of the therapeutic relationship. This was, patients, consumers, people having peer support, peer validation, and there was seemed to be some sense of resolution with that as well. So they were really powerful sessions, and I think as the words on that slide say, each session, because you had a different 10 people with different 10 stories and the way that they may want to interpret their own story and relate it, each session had a slightly different feel to it. And those words are actually what we as the people who are listening in the circle sort of got, what was predominant or what was one of the key themes for that particular circle when we listened to the stories. But no, it was powerful, and it was actually incredibly motivating to make change.
Thanks, Andy. I really appreciate that. Now, we're running short on time. So, Janet, can you just flip to the next slide for me, please? Okay, so this is the second phase. This is when we brought all those responsible parties together for a day's workshop, and all of Mesh Down Under attended that, and they committed to actions that were involved in the public report. Next slide, please, Janet. This is what a circle looks like when you have, this is us preparing for that circle process. So you can see we sit pretty close together. Next slide, please. This is really, this is the kete that's sat in the middle of the circle. Each of the large stones represents a listening circle, and each of the small stones represents one of the people who came and told their stories. That kete was also filled with the weight of the stories from the story database, and everyone that attended as a responsible party, all of us were given a stone to take away on that day. And I often hear from those that attended, they still have them, they have them in their pockets. When they touch them, it reminds them of how they felt from those circles, and it continues to motivate them for change. Next slide, please, Janet. So before I talk about the fact that we are evaluating this, well, I'll just say for this bit, we're evaluating this process for so that we can learn what we need to do to replicate it. I just want to leave the final closing words, if I might, with you, Carmel, around what it felt like. You talked about at the beginning what it felt like to come and have that journey over many years, and to sit in that room with the weight of all those stories and hear from people. I just wondered if there were any last words that you had from us before we conclude our presentation.
Well, thank you. It was quite emotional and overwhelming to walk into that room and see the array of stones and the words. We hadn't been briefed that that would be a graphic representation of what had been going on for all of those months, but it made absolute perfect sense. And then when all of the Victoria University people put all of those stones into that basket and talked about the weight of the stones and the journey that we as patients had been on, it just made perfect sense. Like, yes, that is a graphic representation of what we are doing as consumer advocates, is we are taking this huge weight of responsibility on our shoulders, and we, at that whole day, basically said to the people that were there, take the weight off our shoulders, please help us and put this right. And it was lovely to see how that played out.
Thank you, Carmel. Back to you and Andy. And I just want to acknowledge Stephanie Turner, who's here to provide insights as to how this approach, what affinity it has with Māori Tana and Māori knowledge as well on the panel. Thank you, Ali. I will hand over to you.
Okay, thank you all so much. I never tire from hearing the stories and the amazing work that you're doing. It's so heart-centered and beautiful, and I'm completely inspired. So thank you very much. Just a quick bit of housekeeping. I think Janet needs to send around a quick poll to the participants. And maybe while we're doing that, I'm excited to be able to introduce our panel. So looking forward to some good conversation. And unfortunately, there's not a ton of questions in the chat box, but we met last week, so I know that this group is very capable of chattering on, so I might have to leave it up to you guys to do that. So first of all, I'd like to introduce Stephanie Turner. She is the Director of Maori Health Outcomes for the New Zealand Health Quality Safety Commission and has worked in several executive leadership roles within the New Zealand District Health Boards. Stephanie has managed a non-government organization, established primary care mental health provision, and worked as a family therapist specializing in art therapy. Stephanie's central focus is supporting quality improvement in health systems and practice, facilitating Te Tiriti o Waitangi, accountability into action, and Stephanie uses a Maori worldview and Maori knowledge systems in health system design to advance and improve access and experience. So joining her on the panel today, we have Dr. Brenda Morrison. So Brenda is the director of the Center for Restorative Justice and an associate professor in the School of Criminology at Simon Fraser University, which is in Canada. So she is a social psychologist with teaching, research, and field experience in outdoor education, governance, and justice. She completed her PhD at the Australian National University, and following her PhD, she worked at a postdoc with the Regulatory Institutions Network at the Center for Restorative Justice. In BC, she has served on the Ministry of Justice Performance Review Committee and the Working Group Summits for a Justice System for the 21st Century. In her home community, she's an active board member for the North Shore Restorative Justice Society. Also joining us, we have Dr. Alika LaFontaine, who is an award-winning physician, speaker, alignment consultant, and the first Indigenous physician listed by the Medical Post as one of Canada's 50 most powerful doctors. He is a recognized expert on Indigenous health systems, health policy, institutional bias, racism, and reflective practice. Clearly, we can't list all of his accomplishments, so we will highlight that he played a key role in building an Indigenous Health Alliance, representing more than 150 First Nations across 3 provinces. He is the past president of the Indigenous Physicians Association of Canada and is the medical director of the Northern Indigenous Health Program with Alberta Health Services. He lives in Grand Prairie, Alberta with his family, and he continues to practice as a full-time anesthesiologist. So we were really hoping to bring in a panel that would, in effect, kind of mirror our guests from New Zealand. So really kind of trying to get a sense for what some of these practices could look like in the Canadian context, because we haven't really seen restorative justice or restorative practices being implemented in the healthcare sector yet. So this is an opportunity, I think, to kind of, dig around and see what we can come up with. So perhaps what we can do going forward, just because I don't see a whole bunch of questions yet, is maybe start off the conversation. Maybe I'll just turn it to Steph first of all, just to maybe have a quick chat, Steph, if you don't mind, about how this approach has some kind of an affinity with the Maori teachings and worldviews, and how that fits, if you don't mind starting in on that. That would be great.
Sure. Kia ora koutou. Thank you for that. Well, first up, often the first thing we do is I'd say to you, ko tararua te maunga ko tainui, te waka ko Ngāti Raukawa te iwi, ko Ngāti Huia te hapu, ko Ōtaki te kāinga. And what I just said then is about who my canoe is, and my mountain, and my river, and the place I connect to. So from a Māori worldview, connection is always the first thing that you start with, and the relational is paramount. And because in sharing those things first up around where you're from, but also your links and connection to the environment as ancestors is the starting point to connect, find other connections with each other, and that's a basic, that's a norm, from an indigenous Māori viewpoint, so that we're one and integrated with our environment, and that's with our systems and processes and ways of doing things. And first and foremost, it is about connecting with each other and forming relationship. So, and that's probably the most the norm in any coming together of Indigenous people in Aotearoa as a starting point. So, of course, great synergy with restorative practice. You start with relationship and connection first up. So I've got plenty to talk about in terms of the synergies between Māori worldview and Māori norms, and ways of doing things that have so much synergy with restorative practice. And that's what's really exciting from my perspective about this work in Aotearoa, that the opportunities to utilise Māori knowledge or Indigenous knowledge. Yeah, kia ora. It's probably enough from me on that moment.
I love it. Thank you. And I'm hoping that Dr. LaFontaine and Dr. Morrison, if you guys have anything to add here, just looking at the Canadian context, I'm curious.
Is Dr. LaFontaine on the line? You go first. That would be perfect.
Sure. So I guess the first thing that really struck me about the presentations is that the experiences of patients are pretty consistent across the world, even though we exist in different systems with different structural elements. So my background's Ojibwe, Cree, Métis, and Pacific Islanders, so I'm Tongan. So I have lots of family in New Zealand, and it was great to hear Stephanie kind of share about our connection with the environment around us. And I think what harm does, especially the first time that you experience harm in the medical system, is it really jars this image that patients have that the system is like this thing that they wrap around them, that's really there to support their needs. And very quickly patients realize that when harm occurs, the system's not set up to restore the harm. It's set up to punish the perpetrators, identify when specific rules have been broken. It interrogates the experience of the people who are sharing the harm. And it really puts the burden of change on the shoulders of patients. It's striking with the mesh experience that we've been discussing that patients were able to organize themselves and figure out how to share their stories and then create those relationships. And one of the things that's striking as someone who has experienced secondary harm through going through experiences with my family, and who's on the other side as a provider, an anesthesiologist who actually provides care, is that we often depend on patients to create those relationships and temper the trauma that they went through in order to make it palatable to us as providers to actually engage. And I think when you're talking about restorative practices versus punitive, I'll just underline what Stephanie shared. It's really about connection. And as providers, we're really scared of causing harm to patients, but even more than that, we're scared of unpacking how we contributed to that harm. And it's to the detriment of everyone not figuring out how to walk that path towards restoration. And I think there's a lot to learn from the mesh experience, gathering stories. Every change in health starts with a story and it ends with a story. And people often ask me, well, how do you make change in the system? It comes down to the stories that you tell and how you shape those stories to make sure that people see themselves in it. One of the harms that has had a lot of attention in Canada recently is forced sterilizations of Indigenous women. I can recollect in my residency training having women cry immediately after being told that they were having their tubes sterilized, and me wondering to myself, well, I wonder if the spinal's working properly. I wonder if I'm providing enough pain relief. But it never crossed my mind. Maybe they're having their ability to have children taken away and they did not consent to it. And so part of it can be ignorance, part of it can be, the emotional sensitivity that comes from having to explore your contribution to the harm. But a lot of this comes back to disconnection, just like Stephanie underlined. The system is not set up for us to see each other as people. When there's conflict, we tend to dehumanize each other. And learning from the experiences that have been shared today, that helps us to see the steps we need in order to see each other as people again. Providers who create harm, they may have been involved in something that was totally egregious and inexcusable, but they're still more complex than that. Like we create harm, we resolve harm, we do good care, we do bad care. And I think moving towards a system where we can, see patients as people again, and we can see providers as more than just their mistake, whether it was one time or several times. That's eventually where I think restorative practices will take us. Thank you.
Beautiful, thank you. And Brenda, did you have something you'd like to contribute to?
Sure. Well, first of all, I just want to acknowledge that I'm here on the unceded traditional territory of the Squamish Nation, on Howe Sound, a little island called Nuku'aloquam, and I'm grateful for the teachings that I have received here and elsewhere from the Indigenous people of Canada and also New Zealand, the Maori. And so I am and actually resonating with that, the Squamish Nation has a saying that I quite like. It's called, they say, "Chin-chins to why," and that means to hold each other up. And for me, that resonate strongly with the practice of restorative justice, because that's what we try to do, is hold each other up, and that's how we become stronger individually and collectively. And I'd like to acknowledge the story and the strength of Carmel for bringing this just perseverance. You know, this, no matter where I've looked at the practice of restorative justice, perseverance and humility and strength are all values, because it's not an easy process. So I began my journey in the study of restorative justice and my interest in restorative down in Australia. And now I'm the director of the Center for Restorative Justice here. And so I'd like to not only acknowledge the work being done in New Zealand, and New Zealand in different ways has been at the forefront of the practice of restorative justice. They brought in large criminal justice reforms in the late 1980s. And they're still learning from that process, because there's always these sometimes unintended consequences when you bring out new reforms. So it's not a panacea. It's not going to make everything right away. And I really feel privileged that I'm sitting here on a panel with two Indigenous colleagues, or soon-to-be colleagues, I hope. And because a lot of the wisdom that informs restorative justice comes from Indigenous worldviews and ways of practicing bringing out the best in each other and working through difficult conversations. And so it's really an honor to be here with Indigenous colleagues on either side of the hemispheres. And I think we're really, it's really exciting times, because you know, we operate in these state-based societies within a number of state-based institutions, such as justice, health, education. And I think restorative justice and another idea called responsive regulation has a lot of room and a lot of scope. So I'm really excited that we're now internationally moving into the healthcare system, and it's really a privilege to be here. Thanks.
Thank you so much, Brenda, and our panelists. Allison and I are monitoring some of the questions that have been coming in. So we actually did have a question that came in a little bit earlier, and it's actually for both Carmel and Andy. So going back to our first panel, it's always tricky involving the media. And sometimes the media can be a positive force for change, and sometimes it can detract from the original message. So Mesh Down Under received some very high-profile exposure before the restorative process began. And with your benefit of hindsight, being that you've been down this path, what were your reflections? You know, do you wish that there was no media attention other than what you controlled yourself to connect up with fellow Mesh sufferers, like the use of Facebook group and other? Carmela?
Is that for me? Okay. No, I don't think there's any bad media. All coverage is valuable in terms of raising awareness of the issue. And we did establish some very good working relationships with some particular journalists who took a great deal of time to learn and understand the complexity of what was going on in mesh patients. Having said that, of course, there were times where people that thought that they knew or they had a different opinion, and they had every right to express that in media as well. For example, there was a letter from a doctor basically saying to all media, look, it's a woman's problem, it's all in their pelvic regions, and hernia mesh and abdominal use is perfectly safe, and how dare you scare our audience by alluding to the fact that it's all mesh. And of course they had every right to do that and express that opinion. On the flip side, we still keep coming up with good evidence through excellent claims with ACC, where about 15-20% of them are male hernia people that have major complications So we continue to try and push that side of the story through our media contacts, even though we get that resistance, if you like, through media.
Yeah, can I just add that, look, the media side, obviously very effective for Mesh Down Under and keeping the issue live and moving forward, which was brilliant because we wouldn't have got to this point otherwise. Media can be a distraction at times, but actually in this case, it actually worked out well when we were doing the forums, or considering the forums. It was one way to get the message out there for people to become aware of where the opportunities were. One thing we did do is, as we went down the co-design process and did the forums together, we had an agreement between Mesh Down Under and ourselves at the ministry that we would have full transparency around any media, so we had a no surprises approach. And if one of us was going to go out with a message for whatever reason, we ran it through the other one so that they knew exactly what was going out and why and all that sort of stuff. So it was very much a no surprises, and that worked really well. Well, mostly it worked really well, but when it didn't work well, it wasn't between us, it was actually the media had done something that neither of us were really expecting. So, but no, the media can be very, very useful, but I think that making sure we had full transparency between us was actually incredibly useful as well.
Brilliant. Thanks so much, Carmela and Andy. We do have some questions that came in through the chat box, so I do want to maybe go to Chelsea's question, who, of course, provided some kudos to the panel. This has been incredible, wonderful, and very grateful for the sharing. To all of our panelists, can you share any advice you have for introducing the restorative approach to new audiences? Just a bit of an elevator pitch. You know, Dr. LaFontaine said it's about tailoring the story to the right audiences. So any advice from those that have gone there before or those that are really trying to champion this now?
I can give a thought on that, if you like. So I think one of the advantages that we have in New Zealand was the trust that was placed in our process and our team by Andy and Carmel to be able to go ahead and do this. And because so many people and parties and agencies were involved in the process, today it doesn't seem like a sort of a hippy-dippy thing, sitting in a circle and passing around a talking piece. I've got one here. This is my phone from the mesh process. So I think involving everybody at the outset is really important. Being aware that you are asking people to share stories that are very emotional. So using skilled facilitators, it's not a C1v1 as an approach that we often have in healthcare settings. We have a national collaborative, which I chair, which has representatives from all the agencies, and we're working out together how we think this approach might fit. So it's about looking at those broad principles and then how each party wants to apply them in the same way that Andy and Carmel have described. And then obviously it's about the integrity around the evaluation and ensuring that what you're doing isn't creating further harm, because that's a very important principle as well from a restorative approach. And I'm just going to get others to talk now. Those would be my key kind of thoughts.
I can try. I mean, the very short elevator pitch would be a relational approach to repairing the harm done through building accountability. And sometimes I found that people who already think they know what restorative justice is, they think, oh, restorative justice, that's a police diversion program. It's about victims and offenders. You know, it belongs in the justice system. Don't bring it into the school system or the healthcare system. But it really is just a relational approach to repairing the harm done proactively and reactively. And the interesting thing about this one is that, often restorative approaches are about building horizontal accountability between affected parties, you know. But the interesting thing here is that this is building actually what we call vertical accountability. So with the regulatory institution. And so there's a big power imbalance there. And so designing the process so people feel safe is really important when there are those power imbalances.
Really important point you picked up on, Brenda, and I'm going to put it back to Alika. I think you're just going to come in, so I was going to tap you on this one. Alika spoke to the culture of fear, and as a clinician, how sometimes that's scary for people to have really safe conversations. So we have some questions Diane and Fabiola have really wanted to know from the panelists, and probably Brenda, Alika, and Stephanie. What benefit do you see from restorative justice for healthcare workers that have also been impacted by potentially harm events or even just their traumatic experiences of providing healthcare?
Yeah, so I'll just extend on some of the things that Brenda talked about. And I think it's important for the Canadian experience to underline that we don't have a lot of the same structural things that those in New Zealand have. Like we don't have a patient or consumer bill of rights. Right, we have a fault or loser pays litigation system, so it's not a no fault system where you're not looking at somebody being personally liable for harm in most of our situations, and for the most part, patients don't really have spaces of power. Any of the power that patients fill is usually through litigation or the media or politicking. That space has to be ceded by the institutional players who are in place right now, not just the providers, but also the health regions, the regulators, national protective medical associations, unions. Like there's a long, long list of people who exist in this space who are very, very effective at focusing everything towards a punitive frame versus a restorative frame. I think one of the things that I've heard from the panelists so far is that getting to the point where you're both working towards an outcome and you develop some trust between the different groups. One of the interesting things that I picked up on was, a coordinated communication strategy. Getting to the point where you both know where you're trying to get to and you're interested in supporting each other, because the media sometimes has its own agenda. It wants to get eyes on stories, and sometimes it wants to generate conflict that way. It can get traction as far as coverage and other things, and that's not always in the interest of restorative practices. But getting to that point where you can be honest with the other person and really feel like they're focused on resolving the harm versus, protecting itself from risk, that's a harder place to get to in Canada because we don't have the same sort of infrastructure and starting point. What I encourage patients who are going through the same sort of process of, gathering stories and organizing themselves the way that was shared earlier is, you do have to be aware of the punitive structure. I don't recommend submitting a complaint until you actually gather your information. Don't let them know that you're upset. Don't let them know that you're thinking of filing a complaint until you have all that information. Otherwise, the system will put up barriers to you to obtain that, even though that is your right. As you're moving forward towards restoration, make sure that you're not diluting your experience to the point where there's not an integrity to what you shared. Sometimes in the interest of bringing together partners, sometimes we take our traumatic experiences and we dilute them to the point where they're not offensive anymore. If harm happened, harm happened. Mesh was put in place. I have pain. That is my experience, right? To somehow temper that and say, it's just discomfort or other things. It takes away the soul of the problem that you're actually trying to deal with, and bringing partners around that is starting off at, a point where you're not really discussing things honestly, and the third point that I think we can really learn from the New Zealand experience, specific to the question about, healthcare workers who've been traumatized by their part in the medical harm, is creating an environment where healthcare workers don't have to worry about getting thrown under the bus. Sometimes these things are done because they're standard of care. Putting in mesh is a standard treatment in many medical environments. And I'm aware of patient harm because of the stories that I've heard. I'm seeing locally that we're doing less and less mesh. But the patient experience is not catching up to the marketing of having this mesh put in place by suppliers. And there needs to be a reconnection between the patient experience and healthcare providers, and providers in particular need to have some context that, their participation will be weighed against their actual contribution to the problem. We are very afraid of getting drawn into litigation if we talk about a colleague who was doing things that could potentially create patient harm or that we witnessed patient harm. It's very easy for us to get drawn into, a charge of unprofessionalism with our regulators. The system's not structured to allow us to speak openly about these things. It forces us into these very specific types of interactions, and working through that will help providers better advocate for patients who have experienced harm and talk about it honestly.
I can just chime in quickly. And then it's not an either, like different regulatory systems can work together. It's not an either or, that there's a place for different things, and different things by design create different outcomes. And so in the context, say, of serious violent harm where there's a homicide, how do you repair the harm done when there's a homicide? And so, that's a serious criminal event, and there's a process that to decide guilt or innocent. And then, but we also complement that with a restorative justice process if the family members choose that. And it produces very different outcomes than the criminal justice evidence-based process. And part of that we found of victims who participate in these processes for serious criminal justice cases like homicide is that there's an emotional reparation, and that the symptomology around post-traumatic stress in all its indicators are reduced. And so reducing symptomology of post-traumatic stress goes for everybody involved. And so, so we know that we can reduce the post-traumatic stress not only of victims, but of first responders and stuff, because, post-traumatic stress is a feeling of disorder, of loss of control, and restorative justice through a relational approach can bring that back for people.
Thank you all. I'm just seeing one quick question. Well, I hope it's quick. Well, I guess we'll see. It's probably not. So this is a question from Robin McGee, and probably towards Joe, I'm thinking. How did this approach address fear of reprisal among the harmed patients with respect to their future care? Wonder if that's something that's, has that been evaluated yet?
That's a very loaded question. Thank you, Robin, for that, and just acknowledging you and the contribution I see you're making to try and push for restorative approaches in the Canadian context. I think that's a question you'd have to ask the people who were involved in the process. What I can tell you is that I've just finished the analysis for understanding people's experiences of the process, but I can't speak to that at the moment because it's still going through a rigor and ethics process. But what I would say is that the results are quite promising, but that people throughout the listening circles did mention that some of them would have liked to have had a restorative meeting with their individual clinician that placed the mesh, quite often because they had often gone back to that same person who had made them feel that their experience was not true, as Carmel described in her story, and that would be something that I think we need to do more of moving forward, is having those individual discussions between clinicians and patients, but they take a large degree of preparation to ensure the safety of both of those parties in the facilitation process. The preparation is the bit that will determine whether or not they're successful. But Robin's absolutely right. It's really important when this kind of harm occurs that we make sure that we repair those therapeutic relationships, because often people will know, as you know, Ali, need that ongoing care, and there's a lot of fear around that we can resolve as well. So I hope that answers your question as best I can. Thanks, Ali.
Can I just come in there, if that's okay, just to add to that? Because I think a lot of it is around confidence in the system. And, and the people we heard from had lost a lot of confidence in the health system. And you can imagine why they had when you heard these stories. When the report was published in December, it got really good visibility. All the colleges picked it up and they sent it around to all their fellows and everything. So the report, the stories, the recommendations came out, was widely circulated. And then the press releases from the colleges and the other agencies, they were all acknowledging the harm, and they were all making commitment to progress, change, and strengthen informed consent, and make sure that their clinicians are skilled. Further to that, we also got some commentary back from some of the people who had participated in the circles, that they received apologies from the clinicians that they had been dealing with previously. That wasn't a vast number, but there were some people who said that they actually got an apology from the surgeon who had been involved in the case after reading the report. So there's some individual examples, but also I think the report itself is a means of conveying that change was needed, but that was acknowledged. And I think that in some way gives some reassurance and hope for people who have lost confidence in the system. Now, that's my perception. Whether or not that plays out like that, I've got my fingers crossed it will, but we've still got to follow through and make sure we deliver on the actions.
Thank you so much, Andy. And this concludes the time we have together today. But just such a big thank you for being with us today and sharing. And I'm hopeful that we can work together to continue to spread some of these approaches and to see how this will change, lives and experiences for people who are harmed and clinicians. I think there's huge potential here. So I just look forward to this journey. And thank you all again on behalf of Patients for Patient Safety Canada and the Canadian Patient Safety Institute. And by all means, feel free to get in touch with us if you have any questions, and let's keep this conversation happening. Thank you all.